Hello and welcome. Today, we're going to discuss rectal prolapse, a condition that, while often uncomfortable to talk about, is important to understand. We'll break down what it is, what causes it, how it's diagnosed, and what can be done about it. So, let's dive in. So, what causes rectal prolapse? It's rarely due to a single factor, but rather a combination of issues weakening the supporting structures of the rectum. Chronic straining during bowel movements, often due to constipation or diarrhea, is a major culprit. Pregnancy and childbirth can also stretch and weaken these muscles, particularly in women. Conditions that increase intra-abdominal pressure, such as chronic coughing, heavy lifting, or even prostate enlargement causing straining to urinate, can contribute. Neurological conditions affecting bowel control, like spinal cord injuries or certain nerve disorders, can also play a role. Finally, aging naturally weakens the pelvic floor muscles, making older adults more susceptible. To understand rectal prolapse, let's talk pathophysiology. The rectum is normally held in place by ligaments and muscles of the pelvic floor. In rectal prolapse, these supporting structures weaken or become detached. This allows the rectum to telescope or invert, pushing downwards through the anus. Think of it like a sock being turned inside out. There are actually different types of prolapse, but the underlying principle is the same: a loss of structural support leading to displacement of the rectum. When we look at the numbers, rectal prolapse is relatively uncommon. It affects women much more often than men, with most cases occurring in individuals over 50. The exact incidence is difficult to determine, as many people may be embarrassed to seek medical attention. However, understanding that it's more prevalent in older women, particularly those with a history of childbirth or chronic constipation, helps us identify those at higher risk. The symptoms of rectal prolapse can vary depending on the severity of the condition. In early stages, you might only notice a bulge during bowel movements that retracts on its own. As it progresses, the prolapse may become more frequent and no longer retract spontaneously. Common symptoms include a feeling of fullness or pressure in the rectum, difficulty controlling bowel movements, fecal incontinence, constipation, bleeding from the rectum, and pain or discomfort in the anal area. You might also notice mucus discharge from the anus. It's important to note that these symptoms can also be associated with other conditions, so seeing a doctor for an accurate diagnosis is crucial. Diagnosing rectal prolapse usually involves a physical examination. Your doctor will likely ask about your medical history and symptoms. During the exam, they may ask you to strain as if you were having a bowel movement to see if the prolapse is visible. In some cases, additional tests may be needed. A sigmoidoscopy or colonoscopy can help rule out other conditions, such as polyps or tumors. A defecography, a special type of X-ray taken during defecation, can assess the extent of the prolapse and evaluate the function of the pelvic floor muscles. An rectal manometry measures the strength of the anal sphincter muscles. Rectal prolapse can be classified based on the extent of the prolapse. A partial, or mucosal, prolapse involves only the inner lining of the rectum protruding. A complete prolapse involves the entire wall of the rectum protruding through the anus. An internal intussusception occurs when the rectum telescopes in on itself, but does not protrude through the anus. Knowing the type of prolapse helps determine the best course of treatment. Treatment for rectal prolapse depends on the severity of the condition and the patient's overall health. For mild cases, lifestyle modifications such as increasing fiber intake, staying well hydrated, and using stool softeners to prevent constipation can be helpful. Pelvic floor exercises, also known as Kegel exercises, can strengthen the supporting muscles. However, in most cases, surgery is necessary to correct the prolapse. There are various surgical approaches, including abdominal and perineal procedures. Abdominal approaches involve accessing the rectum through the abdomen, often laparoscopically. Perineal approaches are performed through the anus and perineum. The choice of procedure depends on individual factors. The goal of surgery is to restore the rectum to its normal position and strengthen the pelvic floor. Post-operative care is important to prevent recurrence, with continued attention to diet, bowel habits, and pelvic floor exercises. While not always preventable, there are steps you can take to reduce your risk of developing rectal prolapse. Maintaining a healthy weight, eating a high-fiber diet, and drinking plenty of fluids can help prevent constipation and straining during bowel movements. Regular exercise, including pelvic floor exercises, can strengthen the supporting muscles. Addressing any underlying conditions that increase intra-abdominal pressure, such as chronic cough or prostate enlargement, is also important. Avoiding heavy lifting and proper lifting techniques can also help. The prognosis for rectal prolapse after surgical repair is generally good, with most patients experiencing significant improvement in their symptoms. However, recurrence can occur, especially in elderly or frail individuals. Recent research is focusing on improving surgical techniques and developing new methods for strengthening the pelvic floor. For example, studies are investigating the use of mesh materials to support the rectum and prevent recurrence. Continued research is essential to optimize treatment outcomes and improve the quality of life for individuals affected by rectal prolapse. Thanks for watching.